Okay, so let's talk about vestibular neuritis. Now, vestibular neuritis, as the name suggests, neuritis, as the name suggests, is inflammation of the vestibular part of the eighth cranial nerve, and it's a neuritis, so neuron inflammation. So we have the eighth cranial nerve. It has a cochlear part, which is for hearing, and vestibular part, and we are talking about damaging the vestibular part of the eighth cranial nerve. Now, it is sometimes used synonymously with viral labyrinthitis. Now, in viral labyrinthitis, the labyrinth is involved, and when the labyrinth is involved, the cochlea is involved, and when the cochlea is involved, we also have in this one hearing loss, tinnitus, and things like this. Now, in vestibular neuritis, per definition, it's just an inflammation of the vestibular part of the eighth cranial nerve. So, in vestibular neuritis, we will have vertigo, and we will have nystagmus, right? Because we only have involvement of the vestibular part without the cochlear part. So to differentiate it from viral labyrinthitis, in viral labyrinthitis we have the nystagmus, we have the vertigo, but we also have we also have involvement of the cochlear part. So we also have tinnitus and hearing loss, or both. Okay, so this is just for definition, for differentiation between it. So what caused viral neuritis is not entirely clear, but probably maybe it's a viral infection, maybe. Okay, so what are we talking about in vestibular neuritis about symptoms? Which symptoms are we talking about? As we said, it's mainly about vertigo and nystagmus. Now, if we're talking about nystagmus, it's nystagmus of a peripheral disease, so it's usually horizontal and not vertical. It's unilateral, not changing direction like a central disease, and it's spontaneous. What also is quite characteristic is what is called something like Alexandra phenomena or Alexandra law, I'm not sure, that when the nystagmus direction, or the nystagmus gets worse when we are looking to the damage side. So if we have vestibular neuritis on the right ear, the disease gets worse when we are looking, or the nystagmus gets worse when we are looking in the problem of the ear. So here it is. It's called Alexander's law. Yes, nystagmus intensity increases when looking in the direction of the fast phase. So yeah, when we're looking in the direction of the fast phase, which is the direction of the nystagmus, so we are getting, and let's see, and the nystagmus direction is to the pathological ear. Let's see. Oh, so yes, this is what I was looking for because I didn't remember. So the direction of the nystagmus in peripheral disease is usually away from the pathological ear. Away from the pathological ear. So for example, if we have, I don't know, vestibular neuritis in the right ear, so the direction, right ear, vestibular neuritis, so the direction of the nystagmus is to the left ear. And when I'm talking about the direction of the nystagmus, it means the direction of the fast beating phase. As every nystagmus has a slow beating direction and fast beating. So in peripheral diseases, for example, vestibular neuritis, we have the nystagmus to the unaffected ear, namely the fast component of the nystagmus is to the unaffected ear. So in vestibular neuritis of the right ear, we have fast direction of the nystagmus to the left ear. Okay, now vestibular neuritis usually lasts for about 7 to 10 days. So the patients have nystagmus and vertigo for about that time. They don't have hearing loss in vestibular neuritis. As we said, there is no involvement of the cochlea. There is no tinnitus, remember that. So it's not like Meniere or viral labyrinthitis. It usually subsides within weeks. For diagnosis, it's mainly clinical, but we can use some tests. We can use the caloric test. In the caloric test, we should see a reduction in vestibular response in the disease side. And we can do also other tests to rule out other things like audiological tests. We should not have any hearing loss. We can also do ENG, electronystagmography, when using the caloric test to evaluate for the reduction in vestibular response in the affected side. We can also do even MRI with gadolinium to look for example, vestibular schwannoma. Usually vestibular schwannoma do affect the hearing and cause tinnitus, especially unilateral tinnitus, but we can also do that. And we can also include other things with MRI with gadolinium, for example, brainstem hemorrhage. Of course, the differentiation between central and peripheral nystagmus or peripheral central vertigo is important, as we want to exclude or understand if the vertigo is from central lesion, namely stroke, for example, or from peripheral lesion, for example, vestibular neuritis, as central lesion like stroke are much more devastating, much more emergency, and much more important to identify and treat immediately. And peripheral lesions like vestibular neuritis are much more benign. So there are some ways to try to differentiate between the two. For example, understanding how nystagmus works. For example, we can differentiate between peripheral to central nystagmus. And there is also the Hinds test, and we have to have nystagmus for this, or the Hinds plus test to evaluate for what we think the nystagmus stem from where. For example, in peripheral nystagmus, usually it is unilateral, namely going to one direction, horizontal and not vertical. It's also fatigue with fixation of gaze fixation. And again, the Alexander law, again, that when we are looking in the direction of the fast phase, when we are looking in the direction of the fast phase, which is toward the unaffected side, we get higher intensity of nystagmus. So looking in the direction of fast phase of the nystagmus give us increased intensity of the nystagmus. This is the Alexander law. To the contrary, when we are talking about central nystagmus, we are talking usually about, and very important is to look for other neurological manifestation. Yes, I don't know, dysarthria, dysmetria, weakness, facial depression, all the things that you can think about in stroke. Now in central nystagmus, the direction can be multi-directional. It can also be vertical, which is not characteristic of peripheral nystagmus. In terms of suppression, not suppressed by gaze fixation. And remember, gaze fixation does suppress peripheral nystagmus. In the central nystagmus, not suppressed by gaze fixation. Now, associated symptoms, think about things of stroke, central stroke, like, I don't know, ataxia. He can't walk without a very width of walking. Dysarthria. You have hard time speaking. Maybe diplopia. I don't know, weakness in one side of the body. Okay, and gaze effect. The direction of the nystagmus, or let's say direction of nystagmus, changes. So when we are looking to one side, the direction is this, and we are looking to the other side, direction is that. So in the peripheral nystagmus, we didn't have change in the direction of the nystagmus. We did have the Alexander's law, which says increase or decrease, increase in intensity of the nystagmus, but the direction was the same. Here, in the central nystagmus, we have change of the direction of the nystagmus. So it's very important. So when we think we have vestibular neuritis and not a stroke, for example, or not Meniere, or not purulent labyrinthitis, or not acoustic schwannoma, and not herpes zoster oticus, and not, I don't know, BPPV, then we can treat in anticipation that it is a self-limiting disease, and usually in some weeks it disappears. Sometimes it has residual manifestations, but vestibular rehabilitation therapy can help. So in the treatment, we treat it symptomatically mainly with drugs like anticholinergics or antihistamines, and first generation we are talking about, not second. Sometimes benzodiazepines, even though their utility and efficacy is debatable. If vomiting, so for vomiting we can use, notice that he won't be hydrated, but you can use IV fluids and things like antiemetics, I don't know, metoclopramine or dasterone, whatever, antiemetics. Another thing that sometimes prednisone or let's say steroids are given to reduce inflammation. Now remember that long-term use of depressants of the vestibular part, vestibular suppressants, is discouraged because it can delay the healing of the vestibular part, the vestibular compensation. So long term of vestibular suppressant, for example, I don't know, benzodiazepine or antihistamines, the medications, not encouraged in order to let the vestibular system heal. Okay, so this was about vestibular neuritis, inflammation of the vestibular part of the eighth cranial nerve without involvement of the labyrinth, manifesting with vertigo and nystagmus, but without hearing loss and without tinnitus and without neurological manifestations, with nystagmus of peripheral region with all the characteristics of peripheral nystagmus, unidirectional, Alexander law, without changing directions, without vertical nystagmus, without neurological manifestations. The diagnosis is mainly clinical. You can use a caloric test with electronystagmography or video nystagmography to evaluate for nystagmus in caloric test and see reduction in vestibular function in the affected side. Usually the direction of the nystagmus in vestibular neuritis is to the unaffected side, and when I'm talking about the direction of the nystagmus, it is the direction of the fast phase of the nystagmus, this horizontal nystagmus. So in vestibular neuritis, let me make sure the direction of the nystagmus is to the unaffected side. I'm almost sure, yes, I'm correct. Okay, thank you very much. This was and the treatment is usually symptomatic because we think it is a self-limited disease, and in about a week or two, and some weeks, especially the severe presentation of the vertigo and nystagmus in the first week will subside. We can use until then those drugs that you can see here. Don't use it too much, so you won't suppress too much the vestibular system. And that's it. This was about vestibular neuritis. Thank you very much. If there are any mistakes or correction, please tell me. Thanks for Merck also, because I based on him. And that's it.